I'm super excited about this. I've gotten to work, well, very closely with Tiffani and relatively closely with Dziko and Colin for a while now. So I'm really excited about having them here for this panel on harm reduction and also, thinking about kind of intersections with recovery identity and folks working in harm reduction, but also things that we really need to address within the recovery community around internalized stigma and some of the ways we think about services for folks who use substances. So I'm going to start with Dziko, and if you all want to introduce yourselves and tell us a little bit about your role and how you came to work in the harm reduction space.
Hello? Okay. Microphone, this is fancy. My name is Dziko Singleton. I'm one of two co-coordinators for the Comprehensive Harm Reduction at Health Brigade. I'm a Black woman in recovery. I'm a certified peer. And I just found out about 10 minutes ago I'm now a registered peer with the Department of Health Professions. So, love what I do. Really appreciate being here today.
Good afternoon, everyone. My name is Tiffani Wells. I'm a person in long-term recovery. I am the harm reduction coordinator with the Department of Behavioral Health and Developmental Services. And I came to work in harm reduction because I started off as a certified peer recovery specialist as well with REMS in recovery here at VCU. I'm also a student here at obtaining my master's degree in the rehab and mental health counseling program. So not only is this something I do in my professional life, I also take pride in this in my personal life. And working in harm reduction is something that is dear to me because I came to realize that, abstinence-based is not something that works for everyone. And, when it comes to recovery, there are different pathways. And harm reduction is the way to keep someone safe if they decide not to take abstinent-based. And that is the ultimate goal when it comes to active use. So that's what harm reduction is for me.
Hey y'all, my name is Colin. I use he, him pronouns. I am the other co-coordinator of, is it too loud? I'm the other co-coordinator of the Health Brigade's Needle Exchange Program. We offer in-house and mobile needle exchange as well as other comprehensive harm reduction services. I came to the work through social work. I actually did an internship at Health Brigade and was a mental health provider there, but really saw, and then I volunteered with the needle exchange as it was coming out in 2018, and really saw an opportunity to kind of use my social work skills in different ways that really went out into the community and offered direct access to people in places that were intentionally marginalized or left out of the equation. So I really appreciate the opportunity to be here to share some stuff. I'm actually standing in for somebody else, so I really appreciate Dziko kind of advocating for me to be here, and Tom, you invited me in. He's been a big supporter of our program, so thank you very much.
Awesome. So, and Dziko, do you want to talk a little bit about how you came to work in harm reduction?
Well, I have tons of lived experience. I'm in recovery. The way I came to the work at Health Brigade, a really good friend of mine from years of knowing him in a 12-step program. When I was about 8 days clean, the verbiage I use for myself, I understand it may not be PC or whatever, but I got high, I was about 8 days clean, and I was struggling to find my place. Since I was 18, I've been in every women's prison in the state of Virginia, as well as in New Jersey. It was time to do something different, and I reached out to a friend of mine who works at Health Brigade, and I said, if you hear about any job opportunities. I don't care if it's janitorial, if it's food service, please let me know. And he just never said anything. And I'm like, well, what's up? Did you forget? No, I didn't forget. 2 years later, he approached me. He said, I've been watching you. I've been seeing you put the work in. And there's this opportunity for a new co-coordinator position that I think you'd be perfect for. So I did a ton of Google research on harm reduction. I'm like, well, what is harm reduction, And as I'm reading the definitions that appeared on these Google searches, it's something I've been doing my entire life, and we do in the Black community anyway. It's just looking out. We call it looking out. That's how I formally came to this. I made a promise to myself during my last week of active use that if I could get out of the degradation and the despair of active addiction, that I would reach back and help somebody else. And this is why I believe so passionately in what we do. And it's all because of the therapeutic value of another addict helping another. I refer to myself as an addict in recovery, so I understand the verbiage and the language changes from room to room, but my foundation is absolutely this 12-step fellowship, so that's how I formally came to this work.
Awesome. Thanks, Dziko. So I'm curious if you all could kind of talk a little bit about misconceptions about harm reduction, maybe define harm reduction a little bit further for folks, and then as you kind of answer that, also think about, talk to us a little bit about what principles that are central to harm reduction that can be applied across the substance use continuum.
All right, so one of the biggest misconceptions that I run across is that harm reduction is enabling. What we do is, as I mentioned before, is we try to keep those who are still in active use alive and keep them safe until they are ready to seek treatment or, go take a different route from active use. Anyone who is in active use and is not ready to seek treatment. First of all, seeking treatment should not be coerced or it should not be forced. So while they are still in active use, our job in harm reduction is to make sure they are safe and, to keep them alive. So in that sense, whether it's supplying clean needles, wound care, HIV or Hep C type testing, whatever the case may be, that's what we're going to do until they decide to seek treatment. We are not enabling them, we are supporting them. Enabling may be looking like, supplying them with the substance or, making excuses for them or, just anything other than supporting them. And then I guess as far as the principles, we talk about acceptance. Addiction is not going to go anywhere. It's a prominent thing in our society. If you look at the statistics, overdoses, they increase each year. So that shows that, addiction is not going anywhere. So we have to accept the fact that, it's going to be a problem for a while. Accepting it does not mean that we like it, but it just means that, we have a problem that we need to deal with. Another principle is that it should be non-judgmental. If we're going to accept it and we're going to help, whoever is in active use, then we shouldn't judge them. We should treat, those with substance use disorder with respect, dignity. They're still human beings. Just like someone mentioned earlier, these people should be treated with the same respect as anyone else with a chronic disease. One of the speakers yesterday mentioned that it's a developmental disorder. So when they go and seek treatment or, get services, then they shouldn't be turned away or they shouldn't be looked at less than the human being that they are. And I'm not going to get on my soapbox like other people mentioned, but, another principle that I believe is, social justice. We talk about, different laws like drug policies and things, how we criminalize those that use substances. they, again, they're human beings. A lot of people, some might need, incarceration, but at the same time, that is not a cure-all for all people. Incarceration does not stop them from using. They may go to jail for 30 days and then they come back out and they may go right back to using. A lot of people need rehabilitation. So, just like back in the 70s or the 80s, the war on drugs, it was geared towards mainly black people, to get them off the streets and put them in jail because many more black people started using substances. So a lot of drug policies need to change, to get people help more so than incarceration. So that's my spiel.
Thanks, Tiff.
I'd just like to piggyback off of some of the things that Tiffany said. I think that one of the tenets that at least our program kind of operates off of is that drug-related harms are a direct result of prohibition, of over-policing, of incarceration. So when we talk about harm reduction as an enabling force, it's actually quite the opposite. It's actually addressing the direct realities that face people in their day-to-day lives. And for folks that use drugs, especially who inject drugs, that looks like the overdose crisis that we're seeing right now. That looks like increase in hepatitis C and HIV rates. And what harm reduction offers is an alternative to those traditional ways that we police and address drug-related harms that are a direct result of those exact policies. So I actually think it's quite the opposite, and I think Tiffany put it really well, that it's a system of support for folks that are in active use.
Okay. So next question is really for Tiffany and Dziko. We can start with Dziko. What is it like for you as a person in recovery providing services, kind of in this context, in this who are actively using substances and kind of balancing that with your own recovery journey?
Sometimes that's hard for me to answer because I have so many different emotions. I will always advocate for folks who use drugs, always advocate for them because we were a voiceless tribe, right? I think somewhere along the line lately, I've developed survivor's guilt or remorse a little bit. But I'm proud of what we do because this community and this population is so heavily stigmatized, so over-policed. If it weren't for landing at the Health Brigade, I would not be sitting right here talking to you about the people I serve. I struggled for so long. I was never afforded the opportunity to go to treatment. I have 26 felonies, something that Dr. Vest spoke to, with no new charges. So I have a plethora of emotions. The only time that I ever had an alternate sentence was because my mom came to court and stood up for me and advocated for me. So sometimes it's difficult. Sometimes I just want to take our participants and just hug them and just support them and just walk them to treatment. That's not realistic. So in the meantime, what I can do that's tangible and doable, Colin and I can navigate and make telephone calls when they're ready. There's no pressure. So in the meantime, whatever way we can support you, we show up. I'm so proud of that. This work is super heavy. We have a lot of crying sessions. We have some really difficult conversations in the office. And we have 3 part-time associates who do the work with us. But it is difficult. This is not, happily ever after results every day. We deal with a lot of death, a lot of preventable overdoses, and that begins to weigh heavily. But I believe in what we do because Narcan has absolutely saved my life before. So it depends on which day you ask me this question. But we do good work every day. And I'm so proud and privileged to do what I do, because who better than a black girl from around the way who can still go back into the same communities that I used in, that I stole merchandise from, that I did a bunch of different stuff in, and now I can do some good work. I can bring brand new clean socks out into the community. We can bring food and resources, fresh water, hygiene bags. I'm proud of this every single day, but it's not easy. You know, it breaks my heart. You know, but the reality is, it's a Commonwealth of Virginia problem. It's a societal problem. It's a racial problem. It's a gender problem. And we just do the work every day. So I'm proud of that.
Thanks, Dziko.
I don't think Dziko could have said it any better. You know, for me, it's the same exact thing. It's rewarding. It's disheartening at times, and it's real. It's rewarding because I love what I do. You know, starting with you, Tom, you know, it opened my eyes to a whole different avenue. It took me a while to realize the disease that I had. You know, in the beginning, you know, my substance of choice was alcohol, and you couldn't tell me any different that, you know, an alcoholic wasn't, you know, someone who was on the corner with a brown bag that didn't have anywhere to go. You know, because to me, you know, I was just living my best life, just partying, enjoying life. But when reality hit me and I realized exactly what it was, and I realized, you know, that I had to make some changes, then it clicked. It was like, okay, this is the reality of it. And then, you know, making the necessary changes that I had to make, and then coming to Rams in recovery and seeing things in the recovery world, things started to get rewarding. And then working with you, and then coming to DBHDS, and now I'm able to be in a position where I'm able to make some changes, but then it gets disheartening because it's like you want everybody to get it. You want everybody to, you know, you want everybody to not use substances, and you don't want people to overdose, but the reality of it is that's not going to happen. But the only thing I can do is do what I can do on my end, and as I said, in a harm reduction position, is do what I can do to make sure that, you know, I make the certain changes that I can make to see people stay alive in that position, and, you know, work with people around the community and work with people around the state to get them what they need to be active in their community. And then on the other hand, it's real because, like Dziko said, the Commonwealth of Virginia is a different world. You know, we have all these different policies, we have all these different rules that really need to be changed, but, you know, it's not a one-person job. It's a I don't know whose job it is, but, you know, it's not going to take one day, it's not going to take 1 week, it's going to take years. And then with that being said, you know, you have fear in the community, especially in my community, her community, from people that just don't know what's available to them. Fear that, you know, if they reach out for help, they don't know what the results may be. They don't know if they're going to get locked up. They don't know if they're going to be institutionalized. So, you know, as you mentioned, providing the services is rewarding. Like she said, it depends on what day you ask. You just never know what you're facing when you walk into the office or when you log in that day.
Yeah.
Thanks, Tiffany. Colin, can you, and this is a little off the cuff, but can you kind of describe a little bit more of kind of like a day in the life of somebody operating, you all operate the syringe exchange, and kind of talking a little bit about what that looks like providing services?
Yeah, sure. So our program, and maybe the next question we can talk a little bit about how we frame harm reduction a little bit, but our program operates 4 days a week. We operate in-house at night on Monday nights to make sure that people that go to work from 9 to 5, because people who use substances, you know, I think we have this thing in our head of like who someone is, but I think we know that there's people of all walks of life that use substances and need access to our services. So We operate at nighttime from 5 to 8 for folks that work during the week. And then we intentionally go out on a mobile unit on a van to provide services in 3 different places in the community. And those places are specifically selected based upon a Richmond Ambulance Authority heat map of where they respond to the most overdoses. So we're intentionally going into communities that are the most impacted by the overdose crisis. We go out in the community and we pass out sterile needles, safer use of supplies such as cottons, cookers, alcohol pads, Narcan, and then also education and resources on treatment, community resources such as housing and where folks can access food and that kind of stuff. And then I think we've always done this, but I think especially since Dziko has come along, really focused on being more intentional about addressing needs as a whole. So making sure that we're bringing out clean socks, food, clean clothing when we have it, and that kind of thing. What am I missing, Dziko?
A bunch of stuff.
We
do a bunch of stuff.
We do a bunch of stuff, but I think I think that our program is really cool because it's constantly kind of evolving and growing. We have a lot of hopes for the future. We hope to provide Hep C treatment, hopefully mobily if possible, treatment at Health Brigade for SUD. We're hopefully launching some support groups soon. So when I first started, I actually kind of didn't like, so what the state calls harm reduction programs or comprehensive harm reduction programs. When I first started, I thought that this language was kind of inaccessible. You know, you go out on the mobile van, you say, we're a harm reduction program, and people are like, what the hell is that? So we intentionally kind of changed our program to say harm reduction program / needle exchange. And I think we actually use needle exchange the most because that's the most accessible, known verbiage. But I think especially as we've brought more people on and our team is expanded, we work with 3 other people that help us run the program. We talk a lot about how harm reduction isn't just needles. It's something much broader, and how can we make sure that we're providing comprehensive harm reduction in a way that is supportive of a person in their entirety. It's something that I believe in wholly, that Dziko has made me kind of lean into a lot more, so I really appreciate that.
Of course.
Awesome. So, and again, I'm kind of going off the cuff here, but I know we have a lot of practitioners, we have a lot of peer recovery specialists in the audience, we have a lot of parents in the audience, and you all have these conversations that a lot of folks are not used to having around harm reduction, especially, I think this is applicable to all substance use, but I think especially right now, opioid use, IV use. So can you kind of speak to a little bit what those conversations look like, how you go about having a conversation that's non-judgmental, and it's not about, pushing somebody into recovery, it's about how do I care about your safety and your well-being?
We do this every single day that we go out. I talk to a lot of parents on the phone. They call from all across Virginia. And I'm able to apply conversations that I had with my own mother, who's here, in my active addiction, as well as in my recovery. This is how I'm able to have the empathy. These are really tough conversations. You just don't have, there's no formula for this, How do you give solace to a mom who lost 2 sons to overdose and is struggling with another son? It depends on which day you ask me, right? So it varies. I speak from a place of genuine empathy. I understand. And everybody can't go home and talk to their spouse or their best friend because everybody doesn't understand the complexities of addiction. I do. She does. Colin does. And it changes from day to day, person to person. This is not a linear subject, you know. I have one mom who's been calling me for the past 3 months. She absolutely refuses to believe that the syringe cap and the broken glass stem that she found in her daughter's bag means that her daughter might be injecting drugs or smoking drugs. She just doesn't believe it. So the only thing that I can do is listen to her. And I do this when I'm out at dinner with my boyfriend, when I'm at home watching a really good miniseries, because I understand. As close as I am to my family, I couldn't always confide in my sister who shows up for me in every possible way, but we can have these conversations today. So I stand instead for these folks, family members and loved ones, because I really do understand. When I tell you I understand, I really do. I would not be being honest and transparent if I said that it's not easy, you know. I wish everybody knew the joys that I have today of not waking up dope sick, and came off of probation a month ago after being on since 1993. I wish this for everybody who I come into contact with, but it's just not realistic. So the very most that I can do, and maybe the most valuable thing that I can do, is to listen. Maybe not give advice, just listen. Just listen, because everybody isn't looking for an answer. They just need to get it off of their chest. So that's probably one of the biggest things that I do. I spend a lot of time on the phone.
Yeah, absolutely. In terms of some of those conversations around safer ways to use, like what are some of the messages? Because, you know, you all are so deep in it, and yet, and though we have a lot of providers who, you know, might have somebody who's, you know, IV using substances much less frequently. So I wonder, Colin, if you can give us a little bit of that language, or Tiffani, that language in terms of, you know, what are those conversations about, you know, using clean needles, you know, not buying from different dealers, trying to keep your sources consistent, those kinds of conversations that we should be talking to folks about who are actively using substances.
Well, one thing we emphasize is not to use alone, because in the event that there is an overdose, especially with Revive, and Tiana, who is my partner, the Revive Administrative Support Specialist, one thing we emphasize during the training is that if a person is using alone and they go into an overdose, obviously they cannot administer naloxone to themselves. So that's one thing that we emphasize, is not to use alone. And if, you know, you have someone that is known to be an active user in the household, that, you know, again, this goes back to the principle of acceptance. You know, if someone in the household knows that a loved one in the household is using, you may not like it, but if they're not ready to seek treatment, do what you can to keep them alive and be trained and revived. Keep naloxone in the household, so in the event that they go into an overdose, you're prepared to revive them, and keep it in the house. Everybody in the household has a smoke detector. Everybody in the household should have naloxone, just in case.
Yeah, and that includes folks that have past history with substance use, past history with opioid use, even if, you know, they've, you know, haven't used maybe in a long time.
So with our program, we certainly have and provide education materials that talk about, you know, vein care or hepatitis C. But I think the reality is that most folks that are injecting drugs know what they're getting into. They know these things. I mean, there are like more scientific things that, like, you know, Hep C can stay on a cooker for 45 days or something like that. Things like that is good information to pass along. But I think what our program really focuses on is access. Making sure that people have consistent weekly access to our program so that they have the tools and the sterile instruments to use safely so they don't have to share. Because these things aren't necessarily about people not knowing that sharing is not a good thing. It's because before our program, maybe they had one needle in the household. So I think that we're very deliberate in how we approach it. We try to build relationships before we start to, educate. We leave education materials available for folks, but we really try to build relationships first and then start to have those conversations. Because if somebody walks up to our van and we do a 2-minute enrollment form, which is basically just their demographic information. That's what the state requires. And we don't have to sit there and give a lecture, which is what our program used to do. The next time they come up, they're a lot more likely to have, to feel safe, to feel like they're in a safe space to ask a question that they really have that's going to help them in their life.
Awesome. All right, we've got some time for, actually I want to ask one more about kind of thinking about the recovery community and kind of how, because we have internal work to do within the recovery community, and how you see kind of internalized stigma or stigma within the recovery community and how that both affects you personally, but also affects the work that you do and our community.
Dziko, you're enabling people. You really go to work, you're enabling people, y'all giving away needles. That was something I used to hear at first when I started working here. And I think it's because of lack of education around the subject of harm reduction. A seatbelt is harm reduction, right? So you have to educate folks. I get really defensive about this subject, because methadone is harm reduction. I certainly don't bash folks who have to rely on the support of MAT. I encourage it, whatever it takes, right? And then when you're ready to move from needles and Narcan, methadone, Vivitrol, let's talk about it. We can make space for that. That's the first thing that comes to mind, I guess. So yeah, it's just that conversation. We had Richmond Police pull up on us one day at one of our sites, and he said something about us enabling our participants. And I'm like, well, we're not giving them dope. We're giving them clean, sterile supplies because HIV and Hep C is so prevalent and running wild in the city of Richmond. Overdose has taken away so many people that I love and care for, so this is where the crux of these conversations surround the same question. I'm a proud member of a 12-step fellowship, but there's a lot of isolated thinking because I understand how many different pathways there are to recovery. There is no one formulated way. What works for me may not work for this next person, but I have to respect it, and we work hard to make sure that we can invite people into the conversation, into these safe spaces so they can choose what works best for them.
And I'll piggyback off that. It mainly goes back to enabling, but I won't repeat that because it's the same thing. But there's also, the medical world. When we, again, going back to revive trainings, we literally have to tell people when you make that 911 call that someone is unresponsive, you don't necessarily have to tell them that the person is in a suspected overdose because they may not come. Because of the stigmas and stereotypes associated with substance use. You're not a medical professional, so you don't have to necessarily say that you suspect the person is in an overdose. You can just say that they're unresponsive and they're not breathing. And then there's, again, going back to, treating people with dignity and respect. Sometimes we hear stories about people going to the ER for being treated for an overdose and how they're treated by, the medical staff. So it may not be people in recovery, but that's just the nurses and the people in the ER. And also talking about people in the rooms in recovery, how MAT is not abstinence. even down to mental health medications. You know, if you're taking, especially benzodiazepines, like even though I take mental health medications, I decide not to take, you know, benzodiazepines. That's just a personal preference. But, you know, when I first got into recovery, you know, I would hear people say, well, that's not abstinence because you're taking some type of mood-altering, mind-altering medication. But as a person that's dually diagnosed with a substance use disorder and a mental health disorder, knowing that if one is not in order, then the other will fall off, that's something I need for myself. And some people in recovery, you know, they have this feeling that if you're taking something, then you're not 100% in recovery. So that's just, you know, different things, different misconceptions from people in recovery. And there was one other thing that I completely forgot. It'll come up in a second.
So one question, you know, we're in this space, and several of the speakers spoke to this, where like our drug supply is contaminated. We have more fentanyl in our drug supply. It's less, people don't know what they're using, like in kind of unprecedented levels. And I'm kind of curious about that and how that's played out in your work. Has that changed your work in other ways? What adaptations are you making, or kind of how are you talking about that with your participants?
I just wanted to say real quick on the last question that when the 2020 harm reduction bill got passed, that was folks in recovery that helped make that pass. The recovery community has showed up in really big ways for the harm reduction program in Richmond, and I think that just shouldn't be missed. You know, I think, you know, I can't speak to the recovery rooms and what happens in there and the conversations that you have with your peers, but I do know that there's a lot of folks out there in recovery that are really, really rooting for programs like this and making sure that their communities are safe. So I just wanted to, you know, uplift that. As far as fentanyl and however you want to frame it, some people call it the drug poisoning crisis or fentanyl crisis or opioid crisis. It's really tough. You know, our program has worked for years to get access to fentanyl testing strips. I think that the reality now is that we have lots of access. The state has finally come through. I'm sure you all have followed the quote-unquote crack pipe bill, and which was harm reduction legislation that the Biden administration put through. That sent a lot of dollars into states to buy fentanyl testing strips. But I think that the reality of the drug supply now is that it's so much more complex than just fentanyl, that these strips only provide certain protections. They are a safety mechanism. They are a tool to use and to have in your toolbox to keep you safe. We have a lot of participants that really, really rely on them, that say that they love them. But me and Dziko have this conversation all the time about how it feels like a little too late, a little bit. Fentanyl test strips only test for certain analogs of fentanyl, and we're seeing that more and more analogs are coming about, different substances, more powerful opioids, that kind of thing. And I think that the thing that we focus on is just making sure that people have unlimited access to Narcan. If they need a couple boxes, we have different forms of naloxone. I know that there's some higher powered nasal spray naloxone that is coming out on the market. I think that they're great preventative measures, and I hope that they keep as many people alive as possible. But the reality is that the drug supply issue is a result of prohibition. And until we address that, I think we're going to continue to see a volatile market. And we know that this has disparate effects on communities, poor communities, communities of color. So it's just really sad, and I don't really know how individual harm reduction programs can really change that, other than giving people access to the things that they need to prevent them.